Okay, welcome everybody to the 5th annual Montreal Oscillometry seminar. It's certainly great to be able to get back together and share what we've been doing over the past year. As the slide I put up last year, this is very different doing it on the virtual platform rather in person. And sadly and not surprisingly, it remains the same this year. These events that impact negatively on us in certain ways also give rise to opportunity, and certainly the archiving of the seminar has become a whole lot easier. And a shout out to the Respiratory Effectiveness Group, the think tank in Cambridge, with whom I have the privilege of working. They've been allowing us access to their website to make these recordings from last year's public. And in fact, this year's likely will be posted on a weekly basis, and the program is already up there. So if anybody wants to review from last year or they miss a segment from this year, you should be rapidly able to do it. And thank you, REG, because we still haven't got our website fully constructed, so we need to borrow space on the internet. I remain optimistic that next year will be different, and the now famous Oscillometry Supper will take place in Montreal after a day of excellent science to allow us to network and scheme projects for the coming year. Certainly, as we went into COVID last year, there was a lot of hype about where oscillation mechanics may be able to contribute in our study of this new disease. Sadly, this turned out to be not some disease where we were worried about peripheral airways disease, but it was the terrible beast that we come to know and hate over the past year and a half. However, it did allow us to spotlight oscillation mechanics, I think, more front and center in clinical medicine as people were scrambling to find alternative ways of objectively evaluating the respiratory system in their patients. And here's one such paper from the Toronto group, which makes the point. And many of these authors are, in fact, participants today. So if you have questions, some of this may come up in the discussions. Also, the interest just in general as to where oscillation mechanics may be able to contribute to clinical care and mechanistic understanding of disease has been highlighted. And here's one such editorial that appears in the ARJ from Peter and Raymond. And it reminds us that once upon a time, it was a more understandable entity where we could sweep one frequency at a time using the XY oscilloscope. And I almost wish we could have teaching modes on the modern equipments, because when I teach to clinicians, I think this would be an easier way of understanding it if you're starting from ground zero. Certainly, Michelson's mid-70s contribution, allowing us spectral analysis and then all of the derived parameters we now use, and we're trying to find their place in phenotyping our patients and evaluating response to medications, was a big step forward. However, it may be that there is a place for the old-fashioned approach. The group from Milan, with other friends and family, showed us back in the early 2000s the expiratory airflow limitation that they could elucidate looking at a 5 Hertz monofrequency signal. And certainly in the same vein, Peter Sly and Zoli Antosh built on that with their in-circle collaboration, looking at this point, probably thousands of children and infants with monofrequency 10 Hertz tracking. And I just want to draw your attention to this paper that's now in pre-publication print. So it's available online, and it's a wonderful summary of the monofrequency approach by Zoli, and is a great walk through history and the evolution of the signals that we use in modern oscillation mechanics. So with that, hopefully brief introduction, I'd like to welcome everybody to this 5th edition of the seminar, and just draw your attention to the fact that we've been able to put together 21 presentations, which will be coming from 34 faculty members who represent 21 institutions situated in 4 continents. So truly a global event. And it's your continued interest and participation that allows this event to go forward. And hopefully together we will be able to more securely anchor oscillation mechanics in everyday practice, or at least prove that it has added value to on top of the tools that we currently use. Finally, a shout out to our industry partners that make events such as these possible and allow the oscillometry unit at McGill to continue on with its work. I'm going to turn the screen over to Charlie. And Charlie, as you know, for those of us who were together last year, gave a simply sterling tribute to Arthur Dubois, the pioneer of oscillation mechanics, who had recently passed away. And Charlie reminded us the importance of understanding the old literature and how it serves as a foundation for us to build upon our new understandings, how to design and execute experiments. And it's really at our detriment if we forget that literature. I'm hoping that Charlie will be able to take a similar approach this year and remind us of past research and point us into, give us a good compass with which to go forward as we explore oscillations mechanics role in our clinical world. So with that, Charlie, I'll stop sharing my screen and turn things over to you.
Thanks, Ron. You know, having organized many of these sorts of things, when Ron asked me if I wanted to give a talk, I said, sure, why not? You know, give the guy some help. And then I realized my life got a little more complicated recently. So it was like, what do I have in the archive that I can take out and dust up? Because it won't matter what I say, because I'm going to provide Wayne and Zolly with some therapeutic ripping opportunities. So with that, I'll start. This is a talk I gave about 3 years ago on the occasion of the retirement of a colleague of ours, and I'll illuminate that a little bit for you in a second. Well, this is a kind of a famous diagram, isn't it? It's an amazing thing, actually, when you think about it. Malcolm took Weibel's data that had been published on 4 people from his thesis and with a pencil and paper and drew this diagram. It's in every textbook. Pick up any textbook, there it is. And what's amazing about it is probably wrong for a lot of different reasons. But the journal that it appeared in is kind of interesting. I thought the St. Thomas Hospital Gazette was some sort of New England Journal lookalike, but it turns out when you actually pull the article, and if you get some of the other pages, you discover that in fact, it's just the hospital newsletter that he published this thing in. So it's kind of amazing. You'd publish something in there about the banquet you're having on Thursday, and a diagram shows up in every textbook in the country, in the world, frankly. But it does talk about the fact that because there's so many of them, the resistance of small airways is basically nil. And there we go. Now, to measure that, we used a retrograde catheter, and this is from Jim Hogg. He kindly sent me this, and this is a human lung, as some of you can spot already, not a dog lung. And the catheter, which is stuck here in this airway, can you see my pointer okay, Ron? Yeah, it's good enough. Whoops, what happened there? Anyway, and then with that, you can actually make measurements. Now, it's kind of nice to go back and look at these old papers. They teach us a lot that you forget. I mean, when I first looked at this, I don't know, 10, 15 years ago, once again, I'd forgotten the volume dependence of these sort of more central airways and virtually no volume dependence of the peripheral ones. In fact, this change in resistance is likely mostly due to closure. And we know from wedge bronchoscope studies that David and I have done and others, there's virtually no resistance of a normal lung when you blow air into it. Now, the criteria that Wilcock laid out in 1969 is still valid today, and that is that the resistance of a subject is essentially normal, or in the high end at least. The pressure volume curve on expiration is normal, and the lung is frequency dependent, shown here as frequency dependence of compliance in a measly 4 asthmatics. And if any of you have ever tried this, I have, some of you have, I know, it's hard to do. It's very hard to breathe that fast and try to keep your lung volume something reasonable. but it's not really great for a clinical situation. And I'm going to use this slide, even though it's very incomplete, but to talk about the fact that the airways are very heterogeneous, axially, anyway, and certainly even up in parallel pathways. And they're controlled by different things, the nerves and the distribution, as I'll get into, the receptors, very different. And we can use this to help us tell us where the action is, or where something that is happening in the lung is then manifesting itself, and then in our measurements, in a way of sort of a validation, if you will. Now, this is the first paper I ever did. And it's done in dogs, and I use this retrograde catheter. And I thinking about it, I'm a little surprised not a lot of other people ever really did use it. But what we concluded in this was something about H1 and H2 receptors, because the H2 receptor had just been described in that era. And but we had used histamine as an infusion and found that its sole response in a dog lung was in the periphery. So we thought we'd try to use that, and we did the following experiment. We infused it into ourselves. Now, I can tell you a pretty wild story about that, but there's no chance that's ever going to get through an IRB today. So what we did was to infuse ourselves, and all of the subjects except myself were normal. Yeah, I realized I just put my foot in it there. There you go. And we decided to use different gases of kinematic viscosity based on a great paper that Jeff Drazen had published about increasing the contribution of peripheral airways by breathing helium. In other words, reduce the central component, enhance the peripheral, because helium is more viscous than air. And then we infused ourselves with helium. And the system we had to measure oscillatory mechanics was unbelievably crude. And not much different than what Ron just showed you. And we saw an increased frequency dependence, and we found that helium, we also used sulfohexafluoride, but that's another story. And we found that that enhanced the whole thing, okay? And these subjects had normal PV curves, resistance within normal levels, and were clearly frequency dependent. Now, the person I was asked to honor a couple of years ago was Neil Wouters in Maastricht University on the occasion of his retirement. And his PhD thesis, like mine, was actually also on the forced oscillation technique. And it caused me to go through his studies, which I had been virtually unaware of. Because after I was finished, I went to Montreal for my postdoc and then got into other things. Now, in this first study that Wouters published, he inhaled histamine in a bunch of asthmatics, and he did a lot of people in this study. It was 60 some. I have some notes here somewhere, but it's like 60 people that they inhaled this in, and you could see the response in the real part of the impedance. Marked increase in resistance at the lower frequency, and then at asymptotes at about 30 hertz. And then the reactance shifts down and to the right in a most remarkable way. And in a sense, showed the same things we did, with fancier measurements, clearly. Now, another study he actually did a couple with helium oxygen. And these are, if I remember correctly, these are normals. And in this study, here's the resistance, and I'll come back to the reactance in a minute. And as you breathe helium, all the resistance all across the frequencies drop. Now, in this study, he gave an anticholinergic, ipratropium bromide, and it showed the same thing, okay? Now, both of these interventions are affecting central airways because, one, in reducing the density of the gas, or in this case, removing the tonic tone that we all have in our airways. That if I gave anybody here, as we did in Montreal, atropine or ipratropium bromide, you see a reduction in airways resistance of about 8 to 10%. And because of the distribution of the cholinergic receptors, you know that this is a central airway response. If we go back to look at the reactants, kind of something pretty interesting happens that I hadn't remembered, and that is that the change is really in the high frequencies. And this is pretty incontrovertible, that the changes, which I'd always wondered about at high frequencies, clearly has something to do with gases and their movement in airways in a physical sense. Virtually no change with ipratropium bromide. Okay, so very different. These two interventions are very different, and they give you a very different pattern, just like the histamine did. Now, Meal also did some studies with commonly used drugs, and in this case, it was a beta agonist, salbutamol, and gave some inhalations into a patient group, probably COPD patients or asthmatics. I've got some notes if somebody really cares about it. And the changes he found were not in resistance, as you would think, but rather in reactants. Now, if I sit and quiz the average pulmonary fellow and ask them how does a beta agonist work, they'll tell you that after you excruciatingly extract this out of them, they'll eventually come to the idea that maybe a bronchodilator relaxes smooth muscle and dilates the airways. Nah, that's probably not how it works. It's changing something in the depths of the lung, and I don't think it has anything to do, or very little to do, with smooth muscle. And I would argue that it actually is causing airways to become more open, and you're shifting the lung volumes. Or at least that's a theory. This is another study that Meal performed, and again, I'm pretty sure this is in COPD. And you'll notice on the left, resistance, very little change, except at the very lowest frequency that they used, which was 8 hertz, whereas reactants, profound changes all across the frequency spectrum. In this study, what he did is they gave 30 patients budesonide inhalations. Okay, so now we're looking at something really complicated, which is the inhalation of a steroid. And there was absolutely no change in peak flow, morning peak flow, no change in FEV1. So these patients, the effect is very subtle. And again, he's seeing changes in frequency dependence, and he's seeing changes in the resonant frequency, which is this shaded area. Everything else was it was non-significantly different. Okay. And then lastly, a paper that's of interest to David Kaminsky and I, and that is the effect of cold air. And here, once again, the effects were in the peripheral part of the lung, both in terms of resonant frequency, and this is a pretty stunning effect. So here is resonant frequency baseline, and then several different time periods, different degrees of cold air challenge. Okay, and you get a really nice separation here. What's interesting in Meal's studies is as he went from the histamine inhalations to these sorts of studies, the number of patients he had to use went way down. He went from 60 now to where he's barely using 10 or 12. He then did another paper that I won't present here, but he measured about 100 people, people with disease, and he correlated against all sorts of standard spirometric indices and found a couple of correlations, but they were only 1 or 2, and they weren't particularly strong. And he made a conclusion that I agree with, particularly when I think about the work that we've done in mice. And that is that each of these parameters that we measure, whatever they're measuring, and I think we'll spend the next month or so debating that, are measuring different things, and that they all have some kind of merit. And I don't think we understand them very well. And these kinds of studies that we often forget about are the ones that sort of give us some clues as to the things that we're measuring, and that the patterns that we see before and after an intervention may have a functional meaning, or at least that's our hope, right? And one thing that humans are really good at, and that's pattern recognition. And I think that that going down that pathway, at least from an educational point of view, might be helpful. People always talk about small airways, how to best measure it. And we get into this horrible conversation about 25, 75 and God knows what. And I always remember this paper, and I just remind everybody of it. And that is from Manuel Cosillo and Peter Macklem from Montreal. And the fact that the FEV1 FEC does a pretty darn good job of separating out these things. Now, some of the other indices, closing volume, V ISO-V, and things that involve helium also do as well. But when you think about sort of simple utility, it doesn't do such a bad job after all. So where are we? This is what we thought about in 69, 78. This is what I think about anyway. From a lung function point of view, if I had a patient who had these sort of characteristics using these sets of parameters, which are in a classic lung function lab, I would conclude the person has peripheral lung disease, something going on in the small airways, if you like. And then if you want to use some of these other things, then they're great. I like forced oscillations for a lot of reasons. One is the gas dilution techniques tend to be highly variable and a little tricky to do, whereas this doesn't require so much. But I think it's important that we control for lung volume. I also want to just to put this slide up, mostly to remind myself that I'm nowadays more of a clinical trialist, and I think that forced oscillation has finally reached that stage, and it is being used, frankly, in large cohorts. We're about to start a major cohort here in the United States of some 4,000 people, and we're hoping to measure oscillatory mechanics in at least 1,000 of those. And we now know that it's feasible to do that. We know that the variability of oscillatory parameters is a little higher than FEV1, but the signal size is also greater, so that the power is clearly there. And I think Dr. Wooter's data shows that nicely. And we know that it's some kind of value added proposition. Just what it is exactly, I think time will tell. So what's the way forward in my mind anyway? I think that these carefully phenotyped patient studies that were done way back when are of merit. I think we need to continue to do them. I think there's some real space there. I'm going to once again make a point I've made several times before, and that is we've got to link it to lung volume. Lung volume is sort of kind of the big elephant in the room that we haven't dealt with in a well. And that's why I'm so interested in the kinds of work that Zali and other people are doing with the slow inspirations, expirations. I think there's some real merit in that. I think we need to develop a bit better data sets using, now that we've standardized, if you want to think of it that way, of how to make the measurements in terms of day-to-day variability, reproducibility, and then the really key one, which is the mean clinical, the mean clinical important difference. In other words, what change really matters. You know, I was part of a thing with NIH some years back, and it was pointed out that we don't even know what the mean important difference for FEV1 is. And, you know, we got to make it simple, guys. If we want this to catch on and be adapted largely by our clinical colleagues in the trenches, we got to keep it simple. And I think what you were saying, Ron, earlier was resonating with me. So I wrote this editorial a couple of years back for the NYU paper on the World Trade Workers that was at the anniversary of the World Trade event. And I speculated whether the small airways will rise again. Well, maybe they never really went away, right? So I think we're at an interesting point in time where we can finally bring oscillometry. I'm still having a hard time saying that, Ron. Sorry, oscillometry into the clinic and learn something about what's going on in the lung. Thank you.
Well, Charlie, thank you very, very much. That was an excellent overview, and for something that you just cobbled together at the last minute, it was truly amazing. I would have enjoyed that talk, even if you told me you'd worked hours on it. I think it reminded us a lot of the classic physiology, so congratulations. I don't want to take up a lot of the discussion time. I want to get other people's comments. So just one question I had and one comment. The comment is, I love you showing the frequency dependent compliant work of Anne Woolcock, and to remind people that other people built on it. I know that Roland Ingram a couple of years later showed that smokers otherwise healthy would have a frequency dependent compliance that would disappear on smoking cessation and reappear on resumption of smoking. And for me, that was one of the most convincing pieces of data as a clinician who was looking for a way of characterizing the patients who were supposedly normal, yet I was convinced were ill. The question I have to you is, given the pharmacology experience you have with oscillation mechanics, the work done by Peter Barnes's group over at Imperial College, and a lot of this was published by Omar Osmani, who's now one of the notables from the ERS, using a spinning disc, they are able to make a very narrow distribution of droplet size or of medication size. And as we know, the size of the size matters in aerosol science.
Yeah.
And if you're going to have sort of the 4 to 6 micron, that's a large airway deposition. If you want to hit the small airways, you got to be under 2 microns. And ideally, to study it, you want to have a very narrow distribution so you're sure where your drug goes. And there's nice literature using radioactive labeled aerosols demonstrating this to, in fact, be so. I just wanted you to speculate at what you might find if you were able to take your various classes of drugs and have one that uniformly and uniquely goes to the large airways versus one that uniformly and uniquely goes to the peripheral airways.
Well, I'm going to make a comment, and then I'm going to pass that question off to somebody who knows a ton more about it than I do, and that's David Kaminsky. But my comment is that when I was a grad student, Charlie Reed, who's a very famous allergist, came to me, and we did experiments on ourselves where we inhaled a radioactive technetium and then did gamma camera stands and looked at fast and slow inhalations. And he actually presented that at the meeting one time, and I have the slide somewhere. It's pretty interesting. And then God, what's the guy over at McMaster's name? Anyway, a couple of years later, did a proper study and had it published. But yeah, by just changing the speed of inhalation, you really change the distribution of stuff in the lung. David, maybe you can take Ron's question because you really know a bunch about this.
Thanks, Charlie. Thanks, Ron. Hi, everybody. Thanks, Charlie, for your presentation. It was really nice. Ron, I was just smiling when you were asking your question because, as Charlie knows, that was my first attempt at a big grant about 20 years ago, which I did not get funded. But I've been interested in that for a long time, and that is to say, can we target therapy in the lung using pharmacological principles? And I think we've all been thinking about that for a long time. My ideal would be that someday we could phenotype people, probably using oscillometry and maybe other tools. And then if we had at our disposal the right kind of drugs, select a drug that was more peripherally depositing versus one that's more centrally depositing, and use precision medicine in that way to actually use our phenotypic knowledge to choose optimal therapy. The big question in my mind is, just because that makes sense, I don't know if it would make a difference clinically. You know, it could be that if you just blast the lung with inhaled steroid, no matter where it goes, a patient with asthma will get better. So it remains to be seen if that sort of beautiful theory and concept will work in practice, and I don't know. But unfortunately, we don't have any compound that I know of that's identical pharmacologically, but that comes in 2 different particle sizes or has 2 different deposition patterns. We used to have that when we had CFC propellants, because then we could test beclomethasone in CFC and then HFA propellant. But then the CFCs have been off the market worldwide for many years now. So unless someone else knows, I don't know of any identical compound that comes in 2 different formulations that could actually test that hypothesis.
Yeah, my crude understanding is whether you're in solution or suspension, it makes the difference between whether you have predominantly under 2 micron or above 2 micron. So we'd have to look for an agent like beclomethasone, which I know our 3M version up here, which is marketed under the name of QVAR, is a solution. So supposedly it's an ultrafine. And we have supplysinide also available as an ultrafine here. But I don't have equivalents of these right now in suspension. That would be the bigger size. So yeah, you're right, we're stuck. Well, I'm going to draw upon the audience, and Jeff, you were the commentator for Jeff Fredberg in Boston. You were the commentator for Charlie's talk last year. I was wondering if you might say a few words since you and Wayne were also well versed in the classic literature because you helped write it. So please, Jeff Fredberg and Ben Wayne Minster, I'd like you guys to comment.
Sure. Charlie, that was splendid. I just enjoyed that so much. I was thinking to myself that you're a genuine scholar. I really appreciate that. And
I appreciate the comment, and for another reason we can talk offline about.
All right. I mean, it's you don't see that so much anymore, and I mean that from my heart. Actually, Wayne is another scholar, right? I
haven't said anything.
What'd you say, Wayne?
I just said I haven't talked yet.
Well, I guess it remains to be seen then, right?
But I did want to make a scholarly comment first before a question, Charlie, about your comment about the fact that this figure showing the resistance versus generation appeared in some very unscholarly journal. A more extreme example, historical example of that is the discovery by Röntgen of the X-rays. You know, the first publication of that appeared in the Würzburg Society newsletter, which it was adjacent to birth, wedding, and death announcements. And then suddenly you have this article on a new kind of ray, which revolutionized, science at the time, he later was able to take that article and publish it in Science and Nature, but the first publication was in this little throwaway newsletter from the society.
Well, this isn't even the society; it's the hospital newsletter. It's pretty funny. I found a couple of copies you can pull down. It's pretty hilarious, actually. Obviously, their hospital newsletter was a little more scholarly than the average thing, but
yeah. I must say that the idea of targeting inhaled aerosols, that seems it's a pretty blunt instrument. I mean, you can if you take rapid inspirations, you do tend to favor the apex. I mean, that goes back to Millick Emily a long time ago, Millick's onion and so on. Do fast inspirations, the top of the lung is faster than the bottom of the lung. So you can do kind of crude things like that, but beyond that, it's pretty tough.
I agree with that.
Let me ask a scientific question now, Charlie. I mean, I agree with you 100% that the importance of lung volume in all of these measurements. And I struggle with this with a lot of papers that I review in terms of the histology and the quantitative stereology, where without lung volume, it's almost impossible to make sense out of the data. Although lung volume free data gets published all the time in JCI and other high profile journals, And so my question to you, so it's easy in a dead lung, it's really easy to fix this because you can fix the lung volume, but what would you recommend for doing this in humans? How would you get, a lung volume to normalize all of the things that do need to be normalized by volume?
Well, first, I'm going to make a comment from my clinical days of spending hours and hours and hours reviewing and writing interpretational lung function tests. And pretty quickly, you discard, we were doing Du Bois resistance measurements, and resistance is useless and specific resistance is useless. The only measurement there is specific conductance. Very robust, very stable. Other people have shown how good it is. So even clinically, never mind the physiology tells you that that's what you need to do. Now, how to deal with it is first off, and I've only seen a few people ever do this, and that would be to do the oscillatory mechanics in the context of a body plethysmograph. That's be the ideal way to do it. Short of that, I've always wondered about, and we did do it for one study, but the data kind of got jumbled up and transferred, but is to just do ICs, kind of like what's being done in exercise testing, where you're riding the bicycle and then periodically take a large breath of TLC to kind of assuming TLC doesn't change, which is always kind of a dicey assumption, but that you could at least track it with FRC that way. I don't know if anybody else on the call has had experience trying to normalize the parameters that way, but that'd be the way I'd at least, I'd do it in a box and I'd do it with ICs and hope that the ICs told me the same thing that the box did and in a sense validate the approach.
Mhm.
Does that make sense, Wayne?
Well, the box is great, but you're not going to do boxes in any clinical studies.
No, but
Right,
that's
right.
that's why I was saying we do a smaller study with the box and ICs, and then roll out the ICs as a way of dealing with that.
Okay, guys, I'm
I-
going to and say we should take this. This is a great discussion. This could go on for easily another half hour. So I'll give one last comment to whoever I just interrupted, and then in the interest of time, we're going to have to hand the floor over to the next speaker. But I think you're touching on an extremely important topic, and so we should come back to that when we're all together again. So who did I interrupt? Go ahead.
Jeff, I think.
Yeah, I would just wanted just quickly, Charlie, you touched on lung volumes and closure.
Yeah.
I just want to say that certainly Saul Permit would echo that.
Yeah.
It's all about lung volume. And just many years ago, Roland Ingram and I and Jeff Drazen published a paper where we looked at these were dog lungs, open chest dog lungs, where we used alveolar capsules to look at heterogeneity. And we found that the changes of resistance or compliance that you see really have to do with closure.
Yeah.
Not changes of airway caliber. We always think about airways getting narrow in water. It's all about closure. And we even said in that paper, it's really kind of quantum mechanics. It's how many units are participating,
right,
not units getting smaller and larger.
Well, I violently agree with that, because all our wedged bronchoscope studies and then the studies we did in mice, et cetera, it's all about closure. The closure is the major response of the lung. And I think that beta agonists reverse that. And I have a theory for why that does that. And it has zero to do with smooth muscle. But that's something for a beer at another time.
Okay, great. Well, the latitude I've shown Charlie is only because he gives the anchor talk. Everybody who comes next, I'm going to be a lot more strict with you, Frederick, but it gives me pleasure to welcome Frederick Trinkman from the University of Heidelberg. Frederick has joined the harmonization project, looking at how we can standardize outputs from devices, and we first met, I think, at the Madrid ERS in 2019. So he's become a good friend and colleague, and I'm happy that he's agreed to talk. So I'll give the screen over to you, Frederick, and I look forward to what you have to say. And discussing Frederick's talk and leading off with a question will be Chung-Wei Chow from the University of Toronto, who runs the lung function lab, the Chow labs for the transplant team, as well as looking at other lung pathologies. So Frederick, take it away.
Thanks, Ron. First of all, a big thank you for the invitation and organization, because I can assume that it's a lot of work, and it's great how you take all the people together, and it's a great pleasure to be here. And I'm really excited to give you some clinical overview about applications of oscillometry, which we all love, but taking it from the lab to some clinical parts. And I will share my screen in a second, hoping that you can see it. Just
Perfect.
Thanks. And I had to smile a little bit because I have some of the data we were talking about concerning the aerosol deposition mechanisms and about medication also. And I'm presenting some of the older data, but also some recent data which others we published. And I think it's a good overview and interesting topic. So first of all, please have a look at my potential conflicts of interest, which are balanced and which will not influence any of the things I'm saying today. So I think we can all agree that small airway function is a really complex construct, and I think we cannot narrow it down to one single parameter as we're doing with spirometry, for example. I think that's something we will all agree on. And just to take you through this chart, we have the conventional techniques. I don't have to talk much about them, like spirometry, the body box, transfer factor, formerly diffusion capacity, and so on. Then we have imaging, which is really interesting because it addresses several domains such as perfusion and ventilation and so on. And then we have the more advanced techniques such as washout testing, capnovolumetry, the pheno, inflammation measurements, and of course, oscillometry, which will be the major part in which we will talk about. And this is why we are all here in the end, because we are talking about oscillometry. And I want to break the small airway function, which is really complex, down to oscillometry, which is a really helpful tool. I think we will all agree on that either. And I just want to take you through some clinical background. So we've all have learned from James Hawk and colleagues that the small airways are affected really early in COPD, and many people in the virtual room here have demonstrated that or were involved in the project. So I don't have to talk much about that. In the end, I just want to show you some really recent data and clinical data, which is interesting, because it's a methodologically very interesting and elaborate work, which was published by Sue and co-workers. And he could demonstrate, when comparing never smokers to COPD patients, that of course in patients with diagnosed COPD and impaired spirometry and so on, you have small airway dysfunction, not a big surprise. But you have never smokers, of course, having normal spirometry, and you have severe smokers having about 30 pack years or so. And these these severe smokers, they have small airway dysfunction in 2/3 of cases, despite having normal spirometry. And they also did some invasive measurements and so on. It's just one part of the paper I'm presenting you today. But the main message should be that it's important because you can really show that in a large cohort, it were like 200 people involved, and that small airway dysfunction is really relevant from a clinical standpoint. And same story in asthma. This is data from the Atlantis trial, which has been published like 2 years ago. And just to make the bottom line, small airway dysfunction is present in nearly all of the asthma patients. And you also have some different domains. For example, you have the oscillometry domain here, which is affected. You have washout testing. You also have some traditional parameters from spirometry, and in the end, you have like affection of small airways in over 90% of cases. So what I get asked a lot when I'm talking about oscillometry in a clinical setting and with people who are not so familiar with that, then I get asked, what does oscillometry actually measure, and has it ever been shown? And of course it has. We have heard a lot of data about that, but I just want to present you one clinical recent paper where it has been modeled that you can actually measure small airway resistance using oscillometry. And they modeled the peripheral resistance, and they could demonstrate that this cutoff of about 40% change is a relevant cutoff, and that it's linked to asthma symptoms. This is the relevant point. So there has been a link between the narrowing of the small airways and asthma symptoms in this computational model taken from clinical data. And I will show you some more asthma aspects in a second, but first let me take you to the COPD, where I already showed you that small airway disease is common in COPD. That's not a big surprise, but we already discussed a little bit in previous talk about phenotyping between diseases, which is of course one major topic, but we also did some within phenotyping within COPD, within one disease entity. And this is some data we presented on the 2019 Good Times, when we could all meet in person, where we presented data on phenotyping COPD. And when you have a look on this green area here, this is what we're actually measuring with central obstruction parameters from spirometry primarily. And then we have other tests such as washout testing or tests that aim at emphysema. And we have the small airway domain, where you see a lot of oscillometry parameters notably. And I think the bottom line which we can make from this were a little over 100 patients in this analysis. We have way more today, which is currently in analysis. But I think the bottom line, the interesting bottom line, is that the techniques we use, and a major or an important technique is oscillometry, it extends our diagnostic toolbox considerably. So if we just would have used spirometry, we would just see the patients on the left in the green area. And we have the body box, washout testing, CT, of course, also, but oscillometry is a big part which adds information in phenotyping these COPD patients. It was also demonstrated that small airway disease and these phenotypes may be important for therapy because they are linked to symptoms. And this can be seen that especially in the symptomatic gold stages, so B and D risk classes, you have small airway dysfunction already in like 90% of cases, or 50% even in gold A. So in those early stages, which we call today, I always say it will be seen as a late stage in like 10 or 20 years, I guess. But today we consider that an early stage of COPD. And bottom line, you have like 50% to 90% small airway dysfunction even in these early stages. And what is notable also is that these changes in small airways are linked to typical COPD symptoms like cough, phlegm, and dyspnea. And this is a really important part when talking about therapeutic decisions, which will I come back in a second. So far about COPD, I also teased some asthma data, and this is some very recent work which we published. Mustafa Abdo was the leading author, and we could demonstrate that small airways were linked to asthma control, which others also have demonstrated, of course. It's an interesting but not a completely novel finding. But what's notable about this paper is what Mustafa Abdo found out, that it's also linked to physical activity and vice versa. So when you try to improve asthma control, this leads to a better physical activity, more meds and so on in patients with asthma. And this is not only true for severe cases under biological therapy, but also for patients under triple therapy and so on. So it's of course not the as needed step 1 GINA, and this is not the problem, but it's stages 3 to 5. It's a relevant problem, and by increasing asthma control, by decreasing small airway dysfunction, you can improve physical activity, which is a big point, and in the end also increases quality of life, of course.
Okay, Frederick, just a heads up, you're at the 10-minute mark.
Yeah, thanks, Ron. I'm coming to an end with the last slides, taking it to the therapeutic field, and we already talked about lung deposition and size and how does it matter. And we are all aware that the large particles are are impacted in the larynx and nose and so on. The smaller particles between 1 and 5 micrometers are undergoing sedimentation in the smaller airways, and everything below 1 micrometer is not important because it's diffusing. And this study was also mentioned in the discussion before, so I don't want to spend too much time on that because it was just a comparison of beclomethasone in an extra fine and non-extra fine formulation. And what could be demonstrated impressively from my standpoint is that the extra fine formulation decreases peripheral resistance considerably, and you cannot see anything in FEV1. So in the traditional parameters, you would have missed an endpoint if you just would rely on spirometry. And the other point, what David just came up with, which is important because I think there is indeed one substance which has different galenics on the market today. So you have on the one hand tiotropium via dry powder inhaler, the HandiHaler, and you have the soft mishaler, which is different galenic with a far higher extra fine particle size fraction and so on. And this is data from the Omar Usmani group, which was presented on ERS 2018, where he could demonstrate that when switching patients from the dry powder inhaler, trained the patients and switched them to the soft mist inhaler, he could demonstrate a decrease in small airway obstruction by 30%, which is massive when you compare that to the FEV1 change at the same time, which is around 5%, which lies around measurement accuracy, I'm always saying. And I think this is impressive data because it's a bioequivalent dose of the same substance with 2 different galenics, which is used every day today. And they could demonstrate that there's a 30% decrease in peripheral resistance when using this. So this is the last scientific slide, and with data we presented on ERS in 2020, where we tried to do some early intervention in patients with early COPD, and we used dual bronchodilator therapy early, and we linked that to symptoms. And just to make short, we had these patients with dyspnea as a leading symptom of COPD, and we gave those patients a monotherapy with a beta agonist, and lung function improved a little, and small airway function also improved a little. But the big step in the end here was the dual bronchodilator therapy, especially in those patients with a high symptomatic burden, those patients with a high dyspnea item in the CAT score. They had the most benefit from this early bronchodilator therapy with a dual bronchodilator with tiotropium and olodaterol. So in the end, this is interesting data from a clinical standpoint, which we can already use today, which I think demonstrates quite well, taken together, that small airway dysfunction is important and that it can be made visible with oscillometry even today. So please let me conclude that small airway function is impaired early. We all know that, and oscillometry improves phenotyping in COPD as well in asthma patients. And these changes and these phenotypes may already be relevant for therapy today in asthma when switching, for example, to extra fine formulations, or in COPD where I showed you an early escalation therapy or switching devices in terms of deposition mechanisms. So I think this slide summarizes that quite perfectly, because we have to look early and some things are foreseeable. So I'm looking forward to the discussions. Thanks for having me here and for listening to me.
So Chung Wei, over to you in Toronto. Well, I'll step up to the plate because I know Chung Wei is coming to us from her cottage, and there may be some bandwidth issue, but Chung Wei, I think I see you muted. So if you unmute, you can take over the floor. Otherwise, I'll start off with some questions. Okay, well, Frederick, thank you very much. As always, I love your talks. You have a great way of with the graphics and making it clear. And thank you for picking up the ball with the aerosol science. I'd be happy to hear how the discussion goes, because I had to terminate prematurely a discussion which clearly was could have gone on for another 10 minutes. So we're going to get some more airtime on that. But before I take the floor over to there, I'm going to give it back to Chung Wei, because I see she's now unmuted.
Yeah, can you hear me now?
Very well.
Perfect. I'm sorry about that. And I'm getting a lot of feedback, but Frederick, thank you very much for that. Great. I want to ask about the specific parameters that you use for your evaluation of small airway disease. And I wonder if you could comment about the R5 to 19 versus the AX, which is one of Ron's favorite parameters.
It's an important question, and I like both, because they are both helpful, especially when talking about the differential diagnosis of asthma and COPD and the concordant changes and the discordant changes, which we are familiar with in asthma and COPD patients. And I just showed you the resistance parameters for a start, because this is a good analogy in a clinical sense, because it extends our knowledge, which we're doing with the body box. We talked about specific resistance and so on already in the body, which is it's a parameter that is okay, but that doesn't allow to divide the central and peripheral resistance. So this is what I showed you, but it also works with AX, for example, in COPD. It's a good parameter, of course, in COPD patients showing the changes, but I focus on the resistance parameters just for reasons of comparison from a clinical standpoint.
So can you ever?
So I'm afraid, Chung Wei, we've lost you. David, I'll get you to chime in and maybe pick up on some of the pharmacology data that Frederick was touching on.
Thank you. Thanks a lot, Frederick. I really enjoyed your talk very much. And I had two questions, actually. One was Chung Wei's first question. And I think she was trying to ask, what's the specificity of the R5 minus R19 or AX for the small airways, as opposed to heterogeneity of the small airways, heterogeneity of the small and large airways, airway closure, and other lung mechanical events that could be picked up by those parameters. And my second question was related to what Charlie had mentioned, and that is, does the tiotropium data therefore tell us that there are plenty of cholinergic receptors in the lung periphery?
Not about the receptors. I think the LAMA part is really important because of the innervation of the lung, and we all know that the LAMA is the important drug in COPD, and this is why we focused on that. And I think this is a point that the data by Omar Usmani and colleagues shows impressively. It's a proof of concept, and I also think that this point you made earlier is really important, because we are thinking as doctors. I'm talking as a pulmonologist now. We are thinking way too. We spend way too many less thoughts about the deposition mechanisms and how we're getting the drugs actually to the lungs. And we talked about when getting steroids to the lungs, and the patient will benefit, then it will be asthma maybe, or some eosinophilic COPD patient, for example. But I think this is the point. And just to come back to the parameters you were talking about, and about periphery. So I think the ventilation heterogeneity, it's an important part, which is some sort of indirectly addressed only when focusing on the parameters without volumes, which is clear. We also did some washout testing in addition to that. So we used sulfur hexafluoride washout testing, which has a rather peripheral convection diffusion zone. So we are quite sure that we address the acinar airways or terminal bronchially. So to put that together, I always make the story that that I think oscillometry is a really important tool, and that this washout testing just adds this physiological information, because I think we will never use washout testing on a broad basis in clinical routine. But I think it's important to understand it, to combine the parameters, and then we can see that oscillometry is a really helpful diagnostic tool. And this is why I put it together this way, because I think ventilation heterogeneity is only indirectly assessed from a clinical point by oscillometry, but it's the underlying pathology we all know in COPD and asthma.
Okay, well, we're coming up to 8 o'clock, so I'm just going to leave a brief advertisement. For those of you who are maybe older like me and are looking at that slide that Frederick showed of PC1, principal component 1 versus principal component 2, I think the best way forward are the first 2 chapters of this book, which actually explain principal component analysis very, very nicely. I can tell you we're going to see more of this in the future. So the older folks like me get an understanding of it now. Otherwise, we're going to have the youngins running circles around us. But thank you for showing that slide, Frederick. Thank you for a great talk. And it now gives me great pleasure to turn the screen over to Cindy, who's coming from the Woolcock in Australia, who's going to talk about the variability in airway and lung mechanics, insights from telemonitoring in asthma. Cindy, you and I have something in common in that we both share a fabulous mentor in Zoltan Antosh. Cindy, I believe you were Zoli's first fellow back in the day. Correct me if I'm wrong, or you were not his first. Forgive me, that's Bolance, but you were one of his fellows before your current career as an investigator with the Woolcock. Am I correct?
Sorry, can you hear me now? Sorry, classic
I
mistake.
can hear you fine. Yes.
Okay,
great. And I can
yes,
see your screen.
Thank you. I definitely was Zoli's PhD student. I won't say I was his first, as you so correctly identified. I think Zoli and I was Zoltan and Peter's PhD student, and I think they're now starting to joke about having academic grandchildren. And I'm sorry to say I haven't yielded them an academic grandchild yet, but I'm sure that there are many prolific PhD students out there at the moment, former PhD students out there. So I'm happy to make a start. I think everyone can see my slides. I hope. Give me a thumbs up if you can. I can only see Ron anyway. So Ron, you're my sentinel. Thank you so much for the opportunity to be able to present, and thanks Ron for organizing this. It's my first Montreal Oscillometry seminar. It gives me great pleasure to be here. And I'm going to talk to you today about an area of my research that I've been interested in the last few years, certainly since I've started at the Woolcock, and that is telemonitoring. And I got all excited and wanted to talk about a lot of things. Then I realized I only had 10 minutes. So what I'll do is focus on the most recent telemonitoring trial that we've done, that we've completed in asthma. And I might just draw some experiences from our COPD trials as well. So I guess I hope this works. Here we go. So why telemonitoring? Why bother? Well, I guess the fact that we're all doing this online virtually already underscores why might be advantageous to be able to monitor respiratory patients in their homes remotely. And certainly the events in the past 1.5 years have made us understood just how important this is. But even before COVID started, there was already a rise in the availability of technologies that we can use to monitor patients remotely. The rise of telehealth was already well underway and only accelerated by COVID. There's so many more gadgets and toys that we can use now to monitor health, including respiratory health. And I guess the intuitive idea behind monitoring at home, is not just so the patients don't need to come in the clinic, but it's also potentially allowing us to monitor them with much finer resolution, and hopefully detect before something is about to go wrong. In the case of asthma and COPD, I guess the most relevant event would be exacerbations. But what the question though is, what signal do we monitor? And the problem is that we don't actually have good or timely predictors for exacerbations. The best predictor for an exacerbation for both asthma and COPD at the moment remains having had a previous exacerbation in the last 12 months. And as you can imagine, that doesn't exactly allow you to do much in order to intervene. So in terms of what we can monitor, well, there's symptoms. But we all know symptoms can be quite unreliable. They can be underperceived or overperceived. Underperception, we know, occurs especially in elderly asthmatics and in people with severe COPD, and there are many studies showing this. We could also monitor SATs or respiratory rate, and there's certainly increasing availability of technology, at least to measure SATs and to some extent respiratory rate or breathing rate. And there is some evidence from COPD that these change about 24 to 48 hours prior to a COPD exacerbation. But again, that also doesn't, or at least with the medication that we have available to us, that doesn't allow you a good time window for intervention either. And there's always peak flow. We all love to hate peak flow. There's, but it is a key part in the diagnosis and monitoring of asthma. Certainly when you read the GINA guidelines, that's the case. But peak flow isn't well adopted even in asthma, and even less so in COPD. So enter oscillometry, and I'm sure all of us are not immune to its charms. We all can see the benefits of using oscillometry, which is a relatively simple test to do at home. The patient can have a high chance of being able to do this at home. And many of you would be already aware of the CHROMED study that was published in the Blue Journal a few years ago. And in fact, some of the investigators are probably on this call. I see Pasquale here. This was a multi-center RCT with about 300 patients looking at the value of using oscillometry telemonitoring guided management of COPD. Unfortunately, with that study, it failed to demonstrate an effect on the primary outcome, which was time to first hospitalization. What it did show, though, was that in a subset of the patients, and that is those who had been hospitalized in the previous year, there was a significant benefit in reducing the rate of repeat hospitalizations in that group. So maybe not all is lost. But some of you may be aware also, I am particularly interested in variability of lung function over time, particularly during my postdoc with Urs Frey in Switzerland. And I think just last year we published this paper as part of Sabine Zimmermann's PhD thesis, Peter Calverley and Ramon Fari wrote a beautiful editorial talking about this study, where we showed that in a small group of COPD patients where we monitored them for 8 to 9 months, if you aggregate all their COPD exacerbations together, we found that by looking at the variability of the reactants, not the reactants per se, but looking at the variability over a certain period of time, and in this case, over a 5-day period, and looking at it in a sliding window method, we saw that the standard deviation of the reactants over that 5-day period actually changed 3 days prior to an exacerbation occurring, if you consider all exacerbations as a group. And this change occurred earlier than even the symptoms reported by the patients as assessed using the COPD assessment test. And it's probably further illustrated in this ROC curve here, where you can see that in terms of detecting an upcoming exacerbation, the SD of the reactants, again, indicated in blue on this ROC curve, gives you the highest amount of accuracy or area under the curve compared to the reactants per se, labeled in red, or other forms of variability in this case, the coefficient of variation, and definitely over symptoms labeled in green. These weren't significantly different compared to each other, but I think it was promising results. And if anything, that's in COPD, and if anything, looking at variability of lung function over time probably makes even more sense in asthma, which we traditionally think of as a disease of variable obstruction, variable airway obstruction. And certainly there's several studies now showing that using oscillometry, you do show that variability of lung function measured by oscillometry in asthma is greater than compared to in health. In this case, in this study by the Milan group, it was evident in the coefficient of variation over 2 weeks. And in this study that we published recently, compared to also a range of other diseases, it was higher over a period of 1 to 3 months. So the aims of the study that I'm going to present to you was to demonstrate the ability of home FOT or oscillometry telemonitoring to predict the future risks of exacerbations in asthma and also to assess changes in asthma control. And we use an observational real-world pragmatic setting for our study. And we hypothesized that the variability of oscillometry from daily home monitoring would, number one, predict the occurrence of asthma exacerbations, and number two, would relate to changes in asthma control, regardless of what treatment the patients were on at the time.
Cindy, you're coming up to the 10-minute mark, just to give you a heads up.
I'm in trouble then, but I'll try and zip through it. But this is just a stroke diagram of the study protocol. But all I want you to take home from this is that we specifically looked at asthma patients who were on high dose preventer or controller treatment according to the GINA guidelines. And we did not care whether they had poorly controlled asthma or controlled asthma. We took all comers who were on that dose and we monitored them for 24 weeks. During this monitoring period, we got them to answer questions about their symptoms daily as part of the electronic questionnaire, as well as measure their FOT, as well. And in some patients who gave consent, they also measured peak flow. And once a week, an investigator called them to administer the asthma control questionnaire and also ask questions that would enable us to characterize their exacerbations. So that was for 24 weeks. And the oscillometry was measured using the ResMon device, which was given to us on loan by ResTech in Milan. We looked at a multi-frequency signal from 511 to 19 hertz. The patients were instructed to do 2 minutes of tidal breathing with their nose clip and their cheek supported. There was training provided at the start. And after the measurement, the data was uploaded automatically to the cloud via 3G mobile internet. And the investigator was able to check this data via an online portal once a week. We define exacerbations in terms of moderate and severe, although for this analysis, we've lumped them all together because we didn't have enough of them happening. But the moderate exacerbations was defined in terms of a change in treatment due to an increase in symptoms defined by any one of these parameters. And severe exacerbations was defined in terms of taking oral steroids for 3 or more days or hospitalization. So this is a snapshot of the patients that we monitored. We had a total of 30 at the end of the study, and we recorded a total of 18 exacerbations from 13 patients in total, 13 of the patients. And this is a sample time series where the resistance and the reactants, or specifically the inspiratory part of the resistance and reactants are shown in blue. And I think for the rest of the, it's worth noting for the rest of the presentation, I'll only show you the inspiratory part of the resistance and reactants because we found that that was more sensitive than the whole breath average resistance and reactants, even though they gave us roughly the same answers. The yellow shows you the variability as quantified by the coefficient of variation over a 7-day period of the resistance and the reactants. The red dots show you instances of exacerbation. And I hope you can see from this sample graph that the change in the variability was more pronounced compared to the resistance or the reactants per se prior to an exacerbation or during the exacerbation. So here are some tables, which might be a lot, there might be a lot going on, but I think what I want you to take on from this is that when we looked at the ability of the oscillometry parameters, both mean as well as variability, to predict upcoming deterioration in the asthma symptoms within the next 7 days, and there is a minimal clinically important difference for ACQ, and that's 0.5. We saw that it was the variability of resistance, regardless of whether you express it as an SD or a CV, the reactants to some extent, and also the variability of reactants that was most sensitive to predicting future deterioration in asthma. The one that gave us the best AUC, the best accuracy, was the variability of reactant, of inspiratory resistance. If you change the outcome and look at predicting clinical exacerbations as per the definitions that I've already shown you within the next 7 days, again, we see that it was the variability of resistance that was predictive and not resistance per se. Reactance, interestingly, was also predictive, as was another measure of variability of reactance. But again, the highest accuracy came from the variability of resistance. Now, one of the reasons for wanting to do telemonitoring was part of the work that I did with ORIS, and I won't have time to go into the algorithm which we use to try and calculate a risk for exacerbation based on the patterns that we see in day-to-day lung function. If you're interested, I'm very happy to answer questions, but here are some references. The Milan group, in fact, was working on it at the same time, and we joined forces in 2016 to come up with a combined algorithm that had excellent accuracy in predicting future deterioration in lung function, not clinical exacerbations. Now, when we applied this algorithm to try and predict clinical exacerbations, we were pretty happy with the results. So 66% was the results that you saw in the previous slide. That was just from plain logistic regression of what the variability of the, as defined by COV, of CV. When we used the algorithm published by the Milan group, we got that a tiny bit better to 66.7%, which is not much. We used the algorithm that was published with that I published as part of the my work in Switzerland. We got a fantastic accuracy of 84%. The problem with the algorithm is that it needs at least 2 months of baseline in order to establish what the variability of the of lung function is. So when we combine the two methods to compromise, as a compromise, we got 72% of accuracy. So that was not too shabby. So, and on the basis of these results, where we are now, there's a study now that we are running together with our collaborators with the Milan group, and it will be a commercially sponsored study by Restec, and it's a multi-center interventional study across Australia, France, and Italy in order to be able to collect data from 200 patients, where we will test the use of this algorithm and oscillometry telemonitoring to manage asthma by using an asthma action plan form guided by oscillometry and asthma action plan. So we're very excited about this, and hopefully we'll be able to recruit soon, but at the moment COVID is hampering our plans. I thought it might be useful to compare COPD and asthma, the COPD trial that we've run and the asthma trial that I've just presented to you. So it needs bearing in mind that they are relatively small sample sizes, but I think the experiences that we have are quite interesting. So for one, we had excellent adherence to oscillometry with the COPD data set, and they are up to a median of 95%. And with asthma, it was pretty decent at 86%. And we reason that maybe this is not so surprising because the COPD population tends to be older. A lot of them are retired and quite happy to faithfully make the same a measurement at around the same time every day. Whereas the asthmatic population, they included a lot of younger people who were mobile, who still had to go to work, and so that, considering that, it's actually not too bad either. Although I have to say that we did have to exclude people due to a very low adherence, both at the beginning as well as at the end of the study. Feasibility was good in the sense that we didn't have to exclude many people or much data on the basis of poor quality. But I think what might be more interesting for this group might be relationships with symptoms and exacerbations. So I didn't show you this data, but when you look at in terms of relationship with symptoms, the reactants and the variability of reactants in COPD tended to be related to symptoms, whereas in asthma, it was the reactants per se. But when it comes to predicting the future, so previously it was about current symptoms, but in terms of predicting the the changes in symptoms in the next 7 days, as well as predicting exacerbations in the next 7 days, it was the variability that mattered more. And what's more, in the case of COPD, it was the variability of reactants, whereas in asthma, it was the variability of resistance. And it might not be so surprising if we think of asthma, that classical view of asthma as a disease of increased airway lability. And we muse that in with the COPD. Charlie talked about that reactants probably reflects airway closure, and Jeff talks about it being like a quantum state. And I like to think of it as a statistical distribution where, at any given time, you've got a different airways being closed. And our work that Steve Milne published a couple of years ago also showed that in healthies, reactants is related to FRC, but in COPDs, that relationship disappears and reappears when you try and relate it to ERV instead, because and the idea is that you're reflecting communicating volume. So all this to us is consistent, and that might be why we saw that the variability of reactants over time is the parameter that predicts exacerbations. At least that's how we speculate that might be the case, because if you're looking at it every day and it's a statistical distribution of airway closures, on a different day, it's a different airway that's closed. At least that's how I think it, and very open to discussion. So in summary, good feasibility and adherence in telemonitoring or oscillometry in asthma versus COPD. And it's the day-to-day variations, I think, in the lung function that might provide more sensitive predictors of exacerbations than asthma control, rather than just the resistance and reactants per se. And in asthma, it seems to lie in the resistance, and COPD, it seems to lie in the reactants more. This may improve telemonitoring outcomes. We've yet to see this. And so this is what we hope to test in the near future. And the algorithms that I presented, even as we speak, they're probably going to be supplanted soon. We now have machine learning. And so, there's a lot of things that there's a lot of potential here. So in summary, I'd like to thank all these people, and in particular Sabina, whose PhD I've presented, Karen Patel, who's our RA, who has been through everywhere and installing devices in everywhere, including putting the device on a boat in an island 2 hours away from Sydney, and that was great fun. Jackie Huvanandana, as well as Alessandro Gobi, who has done a lot of the analysis, and Ala has been fantastic from the ResTech side, and obviously all the study participants and the funding bodies that had funded the study. Thank you.
Hey, Cindy, I'm not only going to compliment you on a wonderful talk on an emerging topic, but apologize for stumbling over my words and adding 25 years to your life. I hope we can still be friends despite my having pegged you as much older than you really are. And with that, I'm going to turn the floor over to Rajashi Bisway from Cognita Labs in the US. Their company is currently marketing the sixth oscillometry device. And I know that Rajashi and her company have an interest in home monitoring of oscillation mechanics, which is why I reached out to her to be the discussant. So like any good democracy, I'm going to let us live with the deficit, in this case in time, because I don't want to just gloss over and skip to the next talk. So Rajashi, I hope you're there and that you can take the floor for 5 minutes, share with us your insights, and lead a brief but important discussion.
Thank you, Ron. Can you hear me?
I can hear you fine.
Okay, perfect. Thank you, Ron. And thank you, Cindy, for the absolutely fantastic talk. As Ron mentioned, we also are working in this area of home monitoring and just learning not just about what the data shows, but more from why the physiology of why the variability could be different in asthma and COPD, and how the different areas could change that could cause it was very illuminating. And I was just wondering, so you mentioned that, with early exacerbation, that some of the variability parameters could point to or predict early exacerbation, what time frame would be useful enough clinically that it is early enough to provide some intervention? Is it a 3-day, 7-day, 1 day? I think you had mentioned in one of the papers that 1 day was possible with symptoms, but what time frame is useful to provide a good clinical intervention?
Thanks, Joshi. That's a great question. And in fact, it's one I've asked clinicians myself because I think, I guess with asthma, for instance, if you plan to be intervened, and that's another open research question, isn't it? We don't know what is an appropriate intervention in response to increased variability of lung function. And maybe that's a study in itself. I mean, certainly if we're talking about trying to increase, if we follow GINA guidelines management, you would be trying to step up inhaled corticosteroids, but that doesn't take that doesn't take effect until at least a couple of weeks, from my understanding, and the clinicians can absolutely correct me on this. So we've had lots of discussion with Claude Farah, with Greg King, and we thought about this, and with at least with the pianoforte study, we thought that would be the appropriate way to do it, in which case a week is probably a good time frame. But we also talked about how maybe a study like this, if we can tailor prediction to a particular time frame, wouldn't it then make sense to then try and see what sort of intervention would be appropriate? How can we design new interventions that would work at the appropriate time frame, depending on how well we can predict things? I mean, I talked about COPD earlier, about how respiratory rate can increases within 24 to 48 hours, but there's nothing like this. I don't think there's any intervention that you can do that would do any that will help, but maybe there can be. So yeah, it's a great question. It's an open-ended question, at least where the way from where I'm sitting. I'm very happy to hear other thoughts, obviously.
I'm going to read out a question that Chung-Wei Chow has written, because I know she's still having audio trouble from the cottage. Chung-Wei from Toronto writes, great talk. Is there any evidence that patients with higher variance in oscillometry have higher progression of decrease, I think she may mean of disease, over time?
I'm guessing this is relevant to COPD in particular. I guess I'm just going to take it that way. It's a very interesting question. It's not one that we've had the capacity to study because certainly in terms of COPD, we want to see whether these people end up being, I mean, one of the big questions in COPD is how do you identify rapid decliners, and how do you identify those who are frequent exacerbators, etc. We haven't had the capacity to look at a study for the long enough time to be able to quantify that. And maybe that's something I would port over to people with more resources than me. But yeah, certainly very interesting to look at. We've looked at whether variability of lung function is useful for phenotyping in other situations, but that's all work in progress at the moment.
Ron, could I ask a question?
Sure, go ahead.
Yeah, I understand kind of the push towards kind of practical applications of forced oscillometry, but also that can be informed by mechanism. So two things. One is, I know Jeff Maxim and Peter Macklem studied variability of resistance many years ago. You didn't mention that. And also Jose Venegas followed up on some work from Ted Wilson showing that and this is data based on imaging, that the distribution of resistance and closure in the lung is highly variable from breath to breath, and each deep inspiration kind of erases that. And it's kind of like weather, where different regions of the lung can collapse at different times and so on. That's a spatial heterogeneity, but probably can be reflected in temporal heterogeneity. I think it's important to remember that there's dynamic heterogeneity going on in the lung all the time. And I think what you're measuring is probably a manifestation of that.
I completely agree. Sorry, Jeff.
No, go ahead. I'm done.
Oh, I completely agree. I'm sorry I didn't mention Jeff's work. I cite Jeff's work in everything. So rest assured, we're aware of it. We've had, I don't know if Jeff remembers this, we've had conversations about variability over time as well. And it's also, thanks, Jeff. It's also something that we've talked about, whether or not spatial heterogeneity necessarily translate to temporal heterogeneity. It's discussions I've had with Thilo before, and Thilo was going to model it for me because I'm not much of a modeler. But I also, I mean, but in fact, Jeff's work has also said, I think it was Dennis Leary's work that that looked at that. And so, and I don't know if you remember either, Jeff, but a few years ago at the flow volume underworld, we tried to quantify short-term versus long-term variability. And again, a lot of the work that Jeff was talking about also with Peter Macklem, they all dealt with short-term over minutes rather than over days. And I always, one of the early thoughts when I started on this journey was always remembering Peter Macklem's idea that your short-term variability might well relate to long-term variability. So it'd be fascinating to put all these pieces to the puzzle together to see how they all affect each other. And unfortunately, it's the clinical application stuff that gets you the grant, that pays for the investigations that lead you to look into all these. But thank
Jeff,
you for
Jeff, you bring up a great point, and unfortunately it gets even more complicated than that. There's data coming out from the Robarts, Grace Paraga, and her functional imaging, and it shows that in some asthmatics who are repeatedly imaged with her technique during exacerbation, some will show a moving weathered pattern like you have, while others have a stereotypic signature response in the same areas of the lung go down from a ventilation point of view with each exacerbation quite predictably. So we even have this as a new phenotype of which to be aware, which may impact on what we're going to find.
Well, the polarized helium data, which doesn't allow you to separate time out quite as well, also shows the same thing. Some areas are consistently closing and others are coming and going.
Great.
Okay, well, Jordashi, go ahead.
Yeah, I have just a little follow-up on this. So now that I'm understanding more about variability, I wonder, is it different for different disease groups? So would you consider for asthma the variability, not just in the type of parameter, not resistance versus reactance, but the amount of variability, would it be higher for certain disease groups more than the other, asthma versus COPD? I mean, I know that we have some guidelines when it comes to within session variability, but that's for clinic applications, it's about 10% or 15% of children. But is it something similar that you would expect for daily home monitoring, and is it different for different disease groups?
Well, I think so. I mean, asthma is a bit of a no-brainer. Well, no-brainer. I think everyone expects asthma to be variable, but what's surprising from oscillometry, which is not apparent from spirometry, is that COPD is a very variable, shows a lot of variability as well. And as you mentioned, you briefly alluded, we've seen this in within session variability, but also variability over time. So in terms of extent, I don't know. I don't know for sure, but I love the idea that, Dave Chapman and I, we recently published this review where we sort of showed the idea, like I like to think of all the various measures like airway closure and expiratory flow limitation, ventilation heterogeneity. Like I like to think of them as spokes, bicycle spokes, and different disease probably have different lengths of the spokes. And I think of variability either as one of the spokes or just how these spokes vary over time as well. So, I mean, I think it's definitely it should be definitely part of phenotyping. As to what, I don't know yet.
Well, Cindy, take this as a compliment when we have to cut off discussion. Obviously, your topic has incited a lot of interest. But in the interest of time, we're going to move on. But please, everybody, take these conversations offline. And if we were all together in the real world, which we will be next year, we could continue these conversations during coffee and over dinner. So the next talk is going to be entitled "The Effects of Stimulated Obstructive Apnea on Thoracic Fluid Volume and Airway Narrowing in Asthma." And Azadeh Yadolahai from the University of Toronto is going to be presenting this work from her lab. I had the pleasure of collaborating with them on this and got to know them and their team, sadly only over the internet, and look forward to meeting them in person in the future. And I think this will resonate both with the Halifax group and the Vermont group, which is why I've asked David Kaminsky in Burlington to be the moderator for Azadeh's talk. So over to you in Toronto, Azadeh, and thank you. And I we'll just share with everybody that this is under duress because Azada had a family issue requiring an emergency room visit and was unsure if she'd be speaking to us, but happily she signed in after the meeting started to say all was well. And I hope indeed all is well with your family, Azada. Thank you for talking to us under these circumstances.
Thank you very much, Ron, for having me. And sorry for giving you sort of a heart attack 4:30 in the morning. My apologies. So as Ron mentioned, it's a quite pleasure to be here and giving the talk, and I'm quite interested to hear the discussion after that. And this is a work that we're doing in my lab to look at the effects of obstructive sleep apnea on the thoracic fluid volume and airway narrowing in individuals with asthma during sleep. And one of the things that we are interested in is that the individuals with asthma are having a higher prevalence of sleep apnea than the general population, which is about 30% of patients with asthma have a sleep apnea, which occurs due to the partial collapse of the pharynx during the sleep. And unfortunately, what happens is that in about more than 50% of individuals with asthma, the asthma attacks that lead to death occur during the night. And some of the asthma treatments, such as the inhaled corticosteroid, could actually increase the pharyngeal airway collapsibility and increase the risk of sleep apnea and increase this vicious cycle between asthma and sleep apnea. So what we were interested to look into that whether there are evidence or for the possibility of a pathophysiological link between these two disorders. And this is the work that we started with my postdoc, Dr. Swati Bhattacharya. And what we looked was to investigate the effects of the rostral fluid shift, or the shift of fluid from the lower body to the upper body when someone is supine on the airway narrowing. And to simulate the shift of fluid, we used shock pens or lower body positive pressure, which squeeze the leg and basically move fluid out of the legs to simulate the amount of fluid that moves out of the legs to the upper body during the sleep. And the protocol was a double crossover study. The subjects lie supine for 30 minutes, and then we measured the airway resistance with forced oscillation at the beginning and end of the 30 minutes. And we also measured the fluid volume in the legs and in the thorax with bioelectrical impedance. And the subjects either lie supine with no positive pressure, or in the intervention, there was a lower body positive pressure to simulate overnight fluid shift. And here are the data in both healthy individuals and patients with asthma. So the vertical axis is the change in thoracic fluid volume, and the bars are showing the data in healthy and asthma individuals, either during control arm that they just lay supine, or lie supine, or with the lower body positive pressure. And what we found was that in both healthy and asthma groups, lower body positive pressure caused a larger increase of the thoracic fluid volume compared to the just lying supine. And in response, when we looked at the change in X5 from 0 minute to 30 minutes, or from the beginning to the end of the arm, what we found was that there was no change in the healthy subjects, which is not shown here, but in individuals with asthma, there was a significant narrowing in the small airway, as you could see by more negative X5 during the lower body positive pressure. And this change, or the narrowing, was significantly larger compared to the control arm, suggesting that in patients with asthma while supine, induction of rostral fluid shift provokes a small airway narrowing. So then we took this to the next step and to look at what happens in patients who have asthma and sleep apnea. And what we were interested was that during the sleep apnea, the pharyngeal airway collapses, or narrows, and that will induce more negative intrathoracic pressure or more effort to basically keep the airway open and take an inhale or take the breath in during inhalation. And our hypothesis was that negative intrathoracic pressure during the pharyngeal collapse will pull more blood to the thorax from the extremities, and that will increase the fluid volume in the lungs, induce more fluid, basically coming out of the fluid accumulation in the airways, and potentially more airway closure and narrowing of the small airways. And that's what we try to simulate in the healthy individuals. So what we did was that, again, double crossover study, and this is the work of Karen, my PhD student, who has done all of this work, and this is all her credit. We used the subjects when they were lying down, either they were just breathing normally. Intervention arm, they did 25 Mueller maneuvers, which is basically inhaling against the closed airway to simulate the pharyngeal collapse. Took about 30 minutes. And here is the data again in healthy subjects and patients with asthma. The vertical axis is the change in thoracic fluid volume. The blue bars are the data from the healthy during the control arm when the subjects are just lying supine, breathing normally, and the red bars are the caused an increase in thoracic fluid volume. So the maneuver pulled more blood to the thorax, as we can see, with a significant increase in thoracic fluid volume. And the change in the thoracic fluid volume with Mueller maneuver was similar between the healthy subjects and patients with asthma, suggesting that simulated apneas are in the healthy subjects. There was no change in the airway narrowing or X5 during control or intervention. However, in individuals with asthma, there was a significantly more narrowing or more negative X5 with Mueller maneuvers compared to the control arm. And the amount of the change sorry.
Azadeh, you're at the 10-minute mark.
Oh, my apologies. So suggesting that simulating apneas are inducing more negative intrathoracic pressure, more fluid into the thorax, and more airway narrowing, and that could increase asthma. So in the current study, what we're doing is actually don't have a sleep apnea. And our hypothesis is that in those with asthma and sleep apnea, there will be larger increase in thoracic fluid volume and greater small airway narrowing than individuals without sleep apnea. The protocol is the subjects are doing full polysomnography. We measure the airway. And this is data from 18 subjects. 9 with asthma and 9 without sleep apnea and 9 with sleep apnea. And the bars are showing the changes in thoracic fluid volume from evening to the morning. And what you can see narrowing in these two groups of patients with asthma. And I have to say that at the baseline, there was no difference between the two groups. Individuals who have asthma and sleep apnea, or these blue markers, are having significantly more narrowing of the small airways or more narrowing of the small airways than those without sleep apnea. So to conclude, these preliminary results suggest that patients with asthma and coexisting sleep apnea have greater overnight increase in thoracic fluid volume than those without sleep apnea. And this greater increase in thoracic fluid volume and potentially could help with better treatments in this individual. And I would like to thank our collaborators. Thank you.
Azadeh, thank you very, very much. So David, you're on to lead this discussion surrounding Azadeh's work and the topic in general.
Thank you, Ron. Azadeh, thank you so much. That was a really terrific talk. I'm so impressed with how you can link such a physical mechanical event to a physiological event and a clinical event. A couple things struck me. One is that it was only about 100 ml increase in absolute volume, it looked like, in the thoracic volume in the asthmatics that translated into a significant drop in reactants, suggesting stiffening or closure of the, the airway, the peripheral lung. Do you think, in terms of understanding the anatomy of the lung and the volume of blood in the lung, that 100 mLs is really enough to do that?
Sorry, David. I lost the last part of the last sentence. Could you repeat that again?
Yes, I was just asking how you reconciled the relatively small volume increase that we're talking about here based on your work of about 100 ml that's resulting in such a unique mechanical event. It just seems like the lung is so big as far as its total volume capacity and the fluid volume that 100 ml would be very small.
That's a great point. And one of the things is that what we are measuring here is just the extracellular fluid, and it could be more changes in the fluid that we are not measuring, like in the intracellular fluid. And the other point is that
Sorry, you're broken up on my end as well.
I think the problem is with my bad network. Let me see. I'm going to stop sharing and see if that helps.
Yeah, and try leaving your video off just to see if that makes a difference, and we'll just make do with the audio.
I might interject. Yeah, David, that's a great point. But the possibility is that the fluid accumulates perhaps in the adventitial areas around the airways that matter.
That makes sense. And also, Azadeh, I don't know if you're aware, many years ago, there was a study that demonstrated increased pulmonary capillary blood volume in patients with asthma at nighttime, not with sleep apnea, but just with asthma. And so if there may be true parenchymal increases in fluid as well, which may result in closure, I was thinking. I hope we've not lost you altogether.
Okay, well, I guess then we'll take the discussion offline and give me an opportunity to catch up by 2 minutes because we're accumulating, I thought, a 10-minute deficit. So Azita, thank you very much. And we look forward to an improved internet connection and coming back to this conversation in the future. Now I'm going to turn the floor over to Farah Al-Huda, who is one of our master's students in the oscillometry units here in Montreal. And she's being supervised by Larry Lands, who's one of our, well, the head of our pediatric pulmonary division at the Children's, or as we say up here, the respirology division. And the commentator and discussant following as Farah's talk is going to be Diane Gray, who's part of the N-Circle group. Diane works in Cape Town, South Africa, and has a huge experience studying children and infants with oscillation mechanics. So I think she'll be an excellent person to lead discussion. Farah, I'm very proud of you for your work that you're doing for us. And it's really, really pleasurable to introduce you to everybody. So please take over the screen and share with us your evolving data.
Thanks a lot, Dr. Dan Duran, for the very kind words. So my talk is on the TremorFlow N100, a tool for measuring lung function in newborns. So what can we do with lung function data? It's now known that lung function tracks throughout life, so that early abnormalities actually predict long-term dysfunction. Detecting these abnormalities at a younger age would allow us to start intervention earlier, monitor disease etiology and prognosis. It would also allow us to evaluate early determinants of lung health. Eventually, it could answer questions like whether certain individuals are genetically predisposed to develop lung disease. But before all that, reference ranges are needed using comparable devices and protocols within a variety of populations. So the WaveTube oscillometer has been approved to measure lung function in infants within research. So respiratory impedance is measured by forcing oscillations generated by a loudspeaker at the mouth. The subject breathes through this breathing tube, and pressure and airflow is measured during using the pneumotac. And then there's the bias flow on one side of the microbial filter with the face mask on the other side. So in a 2012 study, the WaveTube had a high success rate in measuring impedance in sleeping healthy term neonates. It's also part of the Drakenstein Child Health Study in South Africa, led by Dr. Diane Gray. But the WaveTube is not quite suited to routine clinical care due to its complex computational requirements to calculate impedance. This electronics box right here only measures breathing patterns. So impedance has to be calculated as an additional step. And it's also less portable with several separate components. So Thoracis has developed a device called the TremorFlow N100. It has the flow head with the pneumotac, and the oscillator sits on the bedside away from the sleeping baby. It's hooked up to a laptop that just spits out all the values for respiratory mechanics, so no additional computations required. The N100 also allows testing by a single technician. It's more portable, making it more suitable for clinical use. It's being used by a team in Birmingham, Alabama to test neonates on the first 3 days of life. Their recent paper found that the N100 not only provided a feasible, non-invasive method to assess lung function, but it was also able to differentiate between health and disease, specifically transient tachypnea of the newborn. So our objective is to validate the N100 by comparing its impedance measurements with those of the current gold standard in infants, the WaveTube. We hypothesize that the N100 will provide measurements with a high level of agreement as shown by an ICC of at least 0.7, and the minimum sample size calculated was 13 to 18 participants. Due to COVID-related travel restrictions, the WaveTube is currently not on hand, unfortunately, so comparison data will be collected this fall, hopefully. Knock on wood. So recruitment occurred at the nursery after delivery. Those who gave permission were contacted 2 months later to book the clinic visit. So at the visit, the bulk of the appointment was taken up by waiting for the baby to fall asleep, or at least be calm enough to initiate testing. So vibrations ranging between 7 to 41 hertz were applied by the device for 5 to 12 seconds, or as long as tolerated by the baby, and a bias flow of 1.5 to 2 liters per minute was added. So we recruited 26 participants, of which 10 were enrolled, 7 females and 3 males. Here are the mean ages, weights, heights, and I'll come back to the boxes. All the participant means are shown here. So to be included in data analysis, it was decided a priori that each variable was required to have at the 7 hertz frequency a coherence value of more than 0.5, and a coefficient of variation of 15% max. So coherence quantifies the effect of noise on pressure and flow signals. So a value of 1 indicates that flow and pressure are perfectly linked by a unique impedance value. And CV is also known as intra-subject variability, and it's being used more and more as a measure of reliability to circumvent the limitations of coherence. So the TrebleFlow software automatically excluded measurements with insufficient data for analysis. And then I excluded measurements or portions of measurements containing breath holds, cries, irregular breathing to get a CV of max 15%. Only 1 participant didn't and will be excluded, but remains on here for now. So after the exclusions, if there were still more than 3 valid measurements to be included in the mean, we chose the 3 closest values obtained at the 7 hertz for impedance, as well as AX values. So these graphs show all the participant means. Females are pink circles, males blue squares, outlier is outlined in red. And when you look at these graphs, there seem to be 2 main data clusters. So 16, 21, 18 over here, and 19, 15, 25, and 26 over there. So what was the difference between these 2 groups? So if we go back to the test condition slide with the boxes, it turns out that it was sleep state. So the first 3 were awake and not quite content when they were being tested, whereas the last 4 were all asleep. Also, coherence seemed to improve when infants were tested sleeping. So it's all like very, very close to 1. And then this box over here shows the 2 participants that we used the bias flow with. And it turns out that CV seemed to improve when the bias flow was added, as you can see right here, and it's much lower than the other CV values that we got. So comparing the 3 who were awake versus the 4 who were sleeping, adding the bias flow in these 2, it seems to have attenuated the value so that they lie between awake and sleeping, but no bias flow is used. So even though our outlier was also sleeping, he was tested in a more upright position compared to the rest, which may explain the high CV. Whoops. So being more vertical, his abdominal contents might have exerted less upward pressure, especially post-feed. Another thing to note is that you've got your 2 data clusters again. Another thing to note is that unlike the Alabama team, we were able to reach FRES. So inertance is considered negligible in infants because of their very compliant lungs, and compliance depends on lung volume. But the other study tested neonates a few days old, while we had infants a few months old. So maybe there's enough growth during this period of development that allowed us to reach FRES. Also plotted graphs of each variable against weight in green and height in yellow, female circles, male squares, outlier outlined in red. As you can see, we found no correlation with weight or height, unlike healthy preschool children who have been found to have an inverse correlation between height and resistance. So we found no difference between testing infants lying flat on the bed versus testing them in their parents' arms. Bias flow seems to improve CV, or inter-subject variability, because it flushes the dead space, without which the same participant would show significant fluctuations in the measurements. Sleep state seems to improve coherence, which, remember, quantifies the effect of noise on signals. So it makes sense that when they're sleeping, they're breathing more regularly, there's fewer artifacts. So, so far, the Trevofo N100 appears to provide a quick, easy way to measure lung function in healthy term 2 to 3 month olds. Thank you.
Ron, can I press on? Farah, thank you so much for a fantastic presentation. It's really exciting to see this work, and I really appreciate your presenting it. And thank you very much, Ron, for inviting me as a discussant. It's good to be here, another one of Zoli's children, and hopefully we'll hear one of his grandchildren present some data later in the program. Farah, I mean, I think you gave a really good introduction as to why a pediatrician like myself might be excited about the development of infant oscillometry. So its potential and to be an important clinical tool and an epidemiological tool. But as we develop this tool, it's clearly crucial that we align efforts so that we develop it in a way that can answer these questions. And so I think this is really exciting to see this preliminary data that helps us look at how we should be doing the measures properly, as well as some of the technical aspects of the equipment. So your comparative data, we'll look forward to seeing that soon after the fall. But I think your data has highlighted some key things about testing, and that being the need for in infants quiet, stable, tidal breathing. And the aspects and how crucial that is as we think about the way we collect data. And of course, you mentioned the bias flow, and I think the positioning is an interesting one. You just had a few children, but I just wonder if you might be able to comment on the relevance and the challenges of including the upper airway in the infant measure, and why positioning might be so important in that regard, in comparison to, say, preschool children and adults where we don't include the upper airway?
Well, with infants, they're almost habitual nasal breathers, and nasal resistance contributes to up to like 50%, I've read in some articles, to resistance. So, sorry about that. Because of positioning, like we're trying to minimize the resistance so that it doesn't eat up even more into the contribution of respiratory resistance. So positioning might be more important, as well as just because of their really small size, they have very compliant lungs, which also affects values.
We did try a shoulder roll. The babies did not seem to appreciate it as much as I would thought. I'm used to dealing with newborns in the NICU and the neonatal ICU, and most of them have shoulder rolls, and it's not a problem. But they get a little feistier at 2 months or so.
Mm. Yeah, I mean, I think, Larry, what I take from what Farah is that what's really important to focus on probably is trying to keep the baby in quiet sleep. And so the way they're used to sleeping is probably quite important, but you can't just let them. So for example, in South Africa, it's very common for children to sleep on their mother's backs, and you clearly can't do that. You need to standardize it. And so you can use ways that don't affect the mechanics of the respiratory system, but try and imitate that, maybe with pressure or whatever. I see Zoli Hantosh is on, and I wondered, Zoli, would you like to comment on this? You've had a lot to do with the development of this technique in infants.
Thank you very much. Thank you, Farah, for this presentation. It's really exciting to see something after birth. I did see this method developing in the early phase in utero, I would say, but it's alive and seems to work. It looks nice as concerns the photo. Of course, it's very early to draw conclusions about the reproducibility and sleep stages based on such a initial low sample. So it will probably reduce the variability when you increase the numbers of measurements, increase the length of the measurements in the same infant, and very importantly, try to look for artifacts, because some values which were reported in these in infants look unrealistic. So resistance like 5 centimeter water per liter per second clearly indicates a huge leak around the mouth, around the face mask or wherever else. So these artifacts should be ruled out first, which needs lots of measurements, inspections, and expertise. My comment would probably focus on the length of the measurement. So it is probably inappropriate to copy the recording lengths of larger children and cooperating children and adults in the sitting position, face mask, no face mask, just support, etc., etc. And then you can remove the mouthpiece and replace the mouthpiece to see how reproducible the subsequent measurements are. In infants, it's a totally different situation, because every time you put on the face mask, the child would resist on cooperating. So taking 5 to 12 second samples after placing on the face mask would probably introduce a huge number of artifacts which would disappear after half a minute. So why not going on? The bias flow keeps a good condition for the rebreathing and other things. It is really not important at this rate what positive pressure at the airway opening is caused by the bias flow, because I suspect this is a low impedance driving system, and that's what the positive airway pressure would come from. So I would encourage you to lengthen the measurements and disregard the first 10, 20 seconds instead of keeping that and just waiting until everything is stabilized. Thank you very much. It's very exciting.
So I actually had a question for you. So when you've tested infants, or even Dr. Gray, were you able to actually keep the mask for 30 seconds? Because even keeping it on for 12 seconds seems like such a win, and we're all excited. And
yeah, so I mean, Zali, are you okay for me to take that? Absolutely, we could, but it was very important that the child was in in deep sleep. If we put the mask on before the child was in deep sleep, then they would rouse again. And so we actually had to be quite patient to wait for that deep sleep, and we would just sort of gently touch their face, and if they didn't respond, and we put the mask on, we didn't actually wait the full 30 seconds. You could see, watching the breathing pattern, that they would settle into it. And once it was stable, then we would start recording, which was usually about 15 seconds. And then we were, and if they're roused, I mean, the bias flow is the great thing. If they're roused and had to put the mask back on, it was always a disappointment, because I think even mask placement itself is risky with leak, and you just don't want, don't want to interfere with the child too much during a measurement. But as I said, it was the sleep state. If they weren't in deep sleep, then it was very variable. And we did that just by we guessed that they were in deep sleep by the way they were behaving. Yeah. Yeah.
Yeah, we plan on implementing something you mentioned at the thoracic meetings. How you would we always try to book the appointments around their nap time. If they have a routine nap time, because not all infants do. But also just like asking them not to let their babies fall asleep even on the way to the hospital, because that was something that happened a lot. Like they would sleep on the ride home and be wide awake once they got to the hospital.
Yeah, and then you have to wait for hours. Yeah, which is
Yeah, the deepest sleep we invoked was in one of the fathers.
Yeah, no, I mean, it is, doing it in unsedated children does take patience, because you have to wait for that. But as your data shows, it's absolutely crucial to get that epoch, I think, of time, to get measures that are going to be useful to see either impact of exposures or, clinical, to be able to answer the clinical questions going forward.
Thanks a lot.
And Jeff Maxim, did you want to read out your question that you just circulated in the chat?
Yeah, well, there's been a discussion in the chat about the less negative X7 values and the smaller AX values that occurred with bias flow that were observed by Farah, which were quite interesting. Likely the answer is there, that if there was some instrument dead space that was alleviated by adding the bias flow, the infant's chest wall and breathing efforts would be decreased because they have enough oxygen or enough breathing. So I think it has been satisfied in the discussion that bias flow is a good thing to add, probably reducing the inspiratory efforts, maybe even expiratory efforts, as the infant tries to compensate for dead space effects.
Yeah, like I feel like even though we only have 2 with the bias flow, I feel like I did see a difference in the infant's like reaction to the face mask. It would be much less like, oh no, what is this, and like start crying.
Right.
Or
the initial question that started it off was whether there was any expiratory resistance with the bias flow, which would increase the airway pressure, which would inflate the lung, which would potentially lead to lower reactances depending on the lung volume dependence of reactants in the infants. But I think the bias flow explanation is and alleviating dead space is a good one.
Well, thank you, Farah. We really look forward to the next installment. And I've just heard from Mareka that her infant machine has just arrived, so you can compare notes.
That's exciting.
Well, that's great. Well, everybody, thank you very, very much for today's participation. We have now paid back the 10-minute deficit. Happily, it appears that 3/4 of us at least stayed on beyond the 9 o'clock time limit, which I think again underlines the interest that we all share in the topic and our commitment to the discipline. So with that, I will end this week's meeting. I look forward to seeing all of you and some new faces as well in a week's time. And I'll send out the link in the days preceding next Wednesday. So everybody have a great week, stay well, and thanks again. Bye.
Thanks, Ron.
Thanks so much, Ron.